reaching you soon after the class. Okay, see, concentrate on the class. That will complete your almost like 70% of your work. Okay, remaining you just have to revise. See, first is about, just forget about the headings there. Just see the image. What does the image say? That is what we are going to see. We'll see what is a question that is asked. A 26-year-old patient, I'm just starting my session with my first question. A 26-year-old patient came with a foul-smelling, frothy discharge. Yes, I'm getting the answer, strawberry cervix. That's very nice. But we will not jump. We will see the question. Okay, that's very good that you know it. Very nice. Good. Many people are answering. Very good. Okay. A 26-year-old patient came with the complaints of foul-smelling discharge, greenish frothy vaginal discharge with intense itching. On speculum examination, they have given this image. What treatment do you recommend? They're not asking identify the speculum examination. They're asking what is the treatment that is given. Very good, Mohammed. I got your answer. Very good. I'll explain. Many people are answering, Suresh. Everybody. Very good. That's a good. It's an easy question. Repeatedly asked question. So as already said, this is this appearance is called the strawberry cervix. Very good. Can anybody say what is the other name that is called for strawberry cervix? What is the other name? Yes, one more name. It is called the colpitis macularis. This is one more thing you have to remember. Colpitis macularis is again the strawberry cervix. Another way of telling is colpitis macularis. Remember, this patient's present with a foul smelling, greenish, frothy discharge. That's a very few words that I have given here. And they present with the intense itching. That is a presenting symptom. And remember, 50% of them can also be asymptomatic. This can also be asked as a question. Half of them can be asymptomatic. So they present with a foul-smelling, greenish, frothy discharge with intense itching. And also they might present with pain. Pain abdomen, can be dyspareunia. And they can also present with dysuria. These are the other features. Okay. What is the treatment of choice that you give? You give treatment is metronidazole, as many of them answered rightly. That is metronidazole. Metronidazole, how do you give? That is also important. You give 2 milligram orally, a single dose, or you give a 500 milligram BD for 7 days. What is the other alternative that you can give instead of metronidazole? What is the other one you can give instead of metronidazole? It is tinidazole. Remember this one also. You should always have another option. Tinidazole that is given. So tinidazole, it is given as a single 2 milligram orally. OD dose it is given. Next, there's another option, that is oral metronidazole for the partner. Is it necessary that you give it to a partner for a trichomonas vaginitis? Yes. So remember, this option is also true. But the appropriate question that is asked, the answer will be metronidazole. And it is also important you treat the partner. And what is the next question? Very commonly asked, many times I have asked this question, direct question, which is the most sensitive diagnostic technique for the trichomonas infection? What is the most diagnostic technique? Please answer this question. Okay, everybody has given as NAT. See, this is practically used, but the answer, the most sensitive is the culture in the diamond media is the answer. Thea Martin media is not the answer. Culture is in the diamond media will be the answer. So remember, this can be a direct NEET question. They will give this question and they'll ask you what is the most sensitive technique for trichomonas infection. You should be able to answer this question. Okay, clear? Any doubts from this first question? First image, any doubts? Okay, I'm proceeding with the second. So what does the second image says? What is the cell? What do you see here? What is this cell called? Very good, rightly said, Absar, Vasuki, Afreen. Jayashri, very good, very good. Everybody are answering. Gayatri, Suresh, yes, this is the clue cell. Okay, this is called the clue cell. What do you mean by clue cell? So here, this is a vaginal discharge taken and it is put under saline microscopy finding. Please excuse me, I have a severe cold and it's damn cold here, so I little have cough here. I'll try to. Okay, it's a saline microscopic picture that you have seen here. It's a clue cell. So what is a clue cell? That is very important. Not just you have to know what you're finding. So what is this clue cell? These are nothing but the squamous epithelial cells that is with a fuzzy border. See, these are the fuzzy borders. Why do you have these fuzzy borders? Fuzzy borders is because of the gram-negative rods that are studding in the epithelial cells. That is very important. So it is because of the fuzzy border. So next question to you, it is about bacterial vaginosis. That rightly said, clue cells will go for bacterial vaginosis. Mukesh Kumar, that's right. It's bacterial vaginosis. I just wanted to know, bacterial vaginosis, is it a sexually transmitted disease? Is it a sexually transmitted disease? Bacterial vaginosis? No. Right. Everybody are right. Yes, it's not a sexually transmitted diseases. Then what is the pathology behind this? Why do you have this? It's not in sexually transmitted diseases. What is it actually? Remember, this is nothing but there is alteration in the microflora. What is the microflora? Specifically, we are talking about, it is about the lactobacilli. The decrease in the number of the lactobacilli, that is about this bacterial vaginosis, which is the most common organism that is causing Gardnerella vaginalis. And very important question. Every time they ask this question, what is the question? What is the criteria to diagnose? Yes, Gardnerella bacilli is replaced by Gardnerella. Very good. So that criteria is called the Amsel criteria. Amsel criteria have 4 parts. One is about the foul smelling discharge. What is the second point? It is the clue cells. What is the third one? pH. pH of more than 4.5. Okay, the acidic part will just go and become alkaline. So next is the whiff test. What is whiff test? You take a vaginal discharge, add a potassium hydroxide where you have a fishy odor, 10% potassium hydroxide. Very good. So that is going to be your answer. So answer this image-based question. This will be easier than many of them are answering. And this topic, remember, trichomonas and bacterial vaginosis, they are very, very important topics. You should know everything of those things. Okay. By chance, if I missed anything, please let me know. Okay. Image-based question. Answer this. A woman complains of offensive, foul-smelling, yellowish discharge without pruritus because there is no inflammation in this. That's a very, very important thing. There is no inflammation in bacterial vaginosis. So there's no, they don't present with itching, but they have a worrisome discharge, lot of discharge, foul smelling discharge. On gram staining, vaginal smear shows a reduced number of lactobacilli and a pH of more than 4.5. A wet mount, show the following picture. What is your answer? You give a clindamycin, metronidazole, or a metronidazole 2 gram as a single dose, vaginal gel. What do you give? See the answer. See, B and C both can be right. The both appropriately most commonly used will be go with the answer. So the answer will be metronidazole 500 milligram twice daily for 7 days. It has to be given. What are used in the diagnosis of bacterial vaginosis? What are the criteria that is used in the bacterial vaginosis? Come on. Answer this question. Well, all are used in the diagnosis of bacterial vaginosis except, what is your answer? Read the question. See, I got somebody answering as A. Read the question properly. All are used in the diagnosis of AMSILS except, don't rush. Please read. Except, see, answer is D. D is the answer. See, CDC criteria is for PID, pelvic inflammatory disease. CDC criteria, recent one is 2018 criteria, that is for the pelvic inflammatory disease. Now coming about two things. One is about the license criteria. See, license criteria. Another one is the Nugent's criteria. See, AMSILs, you know that. License and Nugent is Nugent criteria. Nugent criteria or scoring, it is not routinely used, but it is a gold standard for the diagnosis of bacterial vaginosis. See, both these things, see, license and Nugents, you need not have to know in detail, but it's important to know that license and Nugents, they relatively calculate how much there is a decrease in the lactobacilli population. So that is about whole thing about the license and the Nugents criteria. See, though if you didn't know this license and Nugent, CDC criteria, you would have definitely known. CDC criteria is for PID. Remember? Okay. So when you see a question, I know many of them know this question, but don't jump. Even when I was your this one, I used to jump for the answers. So read properly, then pick an answer. That's very important. Okay. What is this image? What am I showing you? What is this image is about? This is a histosalpingogram. Okay. You have a histosalpingogram. You have 4 images that has been given. So we will go with one by one. So what is this first image is showing? Look at this. What is the first image showing? Look, how is the tube? It's like a small tube like. So what is this? This is not beaded. This is not beaded. I will show you what is beaded. There was somebody have answered. I think it's Nandini. It's not beaded. Yes. Hamid is right. It's lead pipe appearance. It's called the pipe stem appearance. Remember, this is called the pipe stem appearance. So the first image that is showing is about the pipe stem appearance. The next image, what you have, this is not from a textbook. This is a very good journal that has been published on the genital TB very recently. So all the histosalpingogram images, they can pick up from this journal. Okay. This is like a gold standard. So what is this? Very good. I got an answer from Ranjit, Amrita Nair. Very good. It's golf club appearance. Very good. That's a very good answer. Golf club appearance. First we'll identify, then I'll tell you what is causing these things. Okay. Next, what is this image? If anybody can identify. What is the third image is showing you? What is the third image showing you? If anybody can identify this. Very good, Ranjit. Exactly. It's tobacco pouch appearance. Exactly. This is going to be a tobacco pouch appearance. What is many of them have answered. It is a beaded appearance. See how is a beaded appearance? You have a multiple constrictions. You have a gap here. This is called the beaded appearance. So multiple constructions that is seen along the fallopian tube. That is because of the intraruminal adhesions. So you will have, this one is called the beaded appearance. So the first image is about the pipe stem appearance. Second one is about the golf club. So what is this golf club appearance? Here, what happens? The tubes are affected, and here you can see the uterus is a normal shape and size. Tobacco pouch appearance is because there is a conical narrowing in the right tube. That is because of the eversion of the fimbria that is secondary to the adhesions. See, when I say tuberculosis, it is adhesions and scarring. So genital tuberculosis is about adhesion and scarring. And next questions, Dinesh Kumar. Give me a second. Yes, rightly said. See, HSG is contraindicated in genital TB. See, if a woman comes to you with a history of infertility, as a part of infertility workup, we will do an HSG. If you know she is a known case of TB, you will never advise a HSG because it will reactivate the TB. So never do a HSG in a known genital TB case. I'm sorry. So that is very important. Dinesh has rightly pointed. And genital TB, okay, that's okay. It's a contraindication for doing a normal HSG. When I say genital TB, it's only about adhesions, scarring. That you have to remember. Whatever findings you're going to see, it's all about adhesions and scarring. Next, you have to know certain things about genital TB. See, very, very commonly asked question is, which is the most common site that is involved in genital TB? The site, it will be the fallopian tube is the most common site. You can see the tubes are affected. Next will be the uterus. Rarely, it is the ovary. Okay. In fallopian tube, which is the most common site? That is the ampulla. Answer this question, which is the most common symptom they present with? Infertility. So the involvement of ovaries is actually very rare. Okay, Gayatri, let's give 2 minutes. Let me give you 2 minutes. Okay, sorry for the disturbance. We'll start with it. Okay, which is the most common symptom that they present with? It's infertility again. So many patients, they come with infertility. So that's how they are diagnosed. And remember, the tube and the endometrium, that is the uterus, that is the most commonly involved. Then never, the affection of the ovaries is very rare. So mostly they will be, so that point you have to remember, that might be asked as a one of the options. One more. What else you should know about this? There is an increased risk of PID, ectopic pregnancy, Asherman syndrome, and what else? Pyometra. Okay, when I say pyometra, which is the most common cause for pyometra? Which is the most common cause for pyometra? Anybody? See, pyometra, it is the carcinoma cervix is the one very most common cause. Okay. Senile endomet, yeah, that can also be there, but I think the first common cause, pathological cause that you can see is carcinoma cervix. And another very important question they ask is, what are the other HSG appearances? That is a very, very EP is ectopic pregnancy. Okay, I'm sorry. EP is ectopic pregnancy. Okay, that you have to remember. EP is ectopic pregnancy. So what are the other HSG features? It's also equally important. One, I think I don't have a space. Okay, I'll just add a page. Okay. So I will talk about what are the other HSG appearances you have. One is, see, I have some missed out some one of the pictures. I think I will be sharing even that with you. One is tuft tube appearance. These are from the mothit appearance. Yeah, honeycomb thing, I'll be coming. Next one. Next one is cotton wool plug appearance. Now the one is about the floral appearance. Cobblestone. One more is leopard skin. Okay. 1 minute. I think I can show you that. 1 minute. Okay, can you see this? Okay, the first image that you can see is since this is from my computer, I can't write it, but understand this is a tuft tube appearance where you can see there is a multiple small diverticular like appearances that you can see at this end surrounding the ampulla. They produce a caseous ulceration. So it will appear like a rosette, and it's called the tuft tube appearance. And the next image that you can see here is a cotton wool appearance, cotton wool plug appearance. It's just like a cotton that is kept, that is also a reticular pattern producing type of that you can see in the tube. And this one is called the floral appearance. I don't know in what way it's looking like a floral, but its actual is nothing but it's a twisted hydrosulfings. It's get twisted and it will get resemble like a floral appearance. Cobblestone appearance. This is about the cobblestone appearance. And the last one is the leopard skin appearance. This is the leopard skin appearance. These images also I'll share. This can only be for the identification. Okay. Can you see my screen? Do you want to see the images again? Okay, 1 minute. Okay, my computer is visible. Okay, then I can easily tell this. Again, repeat. See the images again. The first image is called the tuft tube appearance. You will get all these images. Okay, not to worry. Tuft tube appearance. You can see this. Okay, tufted tube. The tube initially, see, it is very thin. You can see it's not visible. Now can it's visible? No. Yes. Okay. No. Okay, not to worry. We will see that pictures again by the end. Not to worry. Okay. So these are the other images you have to know. Now quickly we'll look into the questions. Okay. What is the questions? Histosalpingogram shows the following. Identify the condition. So what is the condition? Now we have discussed a lot of things. No point in discussing. Again, asking you what is it? It's tuberculosis and extensive endometrial TB. They present with. What do they present with? Amenorrhea. Very good. It's right. Why they present with amenorrhea? You're not able to see the screen? Oh. Now? No. Now? Yes. So the questions are image-based questions. Histosalpingogram shows the following. Identify the condition. The answer will be tuberculosis. Okay. The extensive endometrial TB, they presents with answer again, it's amenorrhea. Why? That is because of the Asherman syndrome. Asherman syndrome is a factor for the development of Asherman syndrome, genital. So that leads to Asherman syndrome, leading to amenorrhea. So next question is about the complication only we are talking. So what is about the next image? What is this appearance called? They can ask you both in tuberculosis. So they can ask both about the tuberculosis and they can also ask about Asherman syndrome and ask a question on tuberculosis. So what is this image is showing? Okay, when I talk about when I talk about the treatment and all those things, yeah. See the filling defects. What are the other things they were discussing? Vignesh, Hamid, they're talking about the filling defects and this one. See, filling defects, hydrosalpinx, all these things are again a part of genital TB. But what you see in Asherman syndrome, what is this typical appearance in HSD that is showing? It's called the honeycomb appearance. So this is called the honeycomb appearance, what you're seeing. Okay. This is called the honeycomb appearance. And what is this Asherman syndrome? Asherman syndrome is the intrauterine synechiae formation. Synechiae is nothing but the adhesion formation. Which is the most common cause? Next question they can ask you is, which is the most common cause? The most common cause, you do a DNC, that is in the postpartum period following an abortion. And very recent, now, just now we have seen genital TB can be a cause. And very, very important question. Initially, they present with hypomenorrhea, that is decreased flow. Gradually, that is when the fibrosis is very less initial. After that, when the fibrosis increases, the adhesion, the synechiae between anterior and the posterior wall increases. What happens? That leads to amenorrhea. That is very important. What is the other presenting symptom? Another is the infertility. What are the other causes that you can think of? Any surgeries, that is scarring the uterus. Causing scarring the uterus, it's gonna be a cause. That can be a risk factor. Need not that if they do a cesarean, definitely they're gonna go into a Asherman syndrome. That is can also be a risk factor for the development of Asherman syndrome. Understood? So don't come to a conclusion that they do cesarean, they'll go into Asherman. It's not that way. It's a risk factor. Okay. Another very important thing is, what is the investigation of choice here? What is the investigation of choice? It is hysteroscopy. Okay, hysteroscopy is the investigation of choice. It is both diagnostic. See, HSG, you can view and say this is the condition. To be both for the diagnostic, yes, this is the diagnosis. Diagnostic as well as for therapeutic, hysteroscopy will be your answer. And what is the treatment that you give? Is adhesiolysis. What you give is the adhesiolysis. You do a adhesiolysis using a hysteroscope. And very important, once you have adhesion has been broken, but you should prevent the anterior and posterior wall again coming in contact. So you give a estrogen progesterone, or you can use a balloon catheter. See, copper T is difficult. Again, copper T you will not use. You use a balloon catheter. Copper T is difficult to maintain. Okay, so balloon catheter you can use. And estrogen progesterone. Estrogen progesterone is given to rebuild the endometrium. So that's how the process will be going on. So you will give adhesiolysis, you'll use a balloon catheter. Following that, you will start the estrogen progesterone to rebuild the endometrium. And what we'll see the questions. HSG showing the following condition. All of the following symptoms can be seen with this condition, except, what is your answer? See, I have made it as amenorrhea. I made a spelling mistake. See, it is oligomenorrhea. Answer is oligomenorrhea. It's not menorrhea. It's amenorrhea. Okay. Next question. See, this was a previously asked question, previous NEET question. Answer this. A secondary amenorrhea with recurrent pregnancy loss and normal serum estradiol levels, FSH level, all can be the causes except cesarean section, myomectomy, following vaginal delivery, tuberculosis. The answer is very straight cut here. It is following vaginal delivery. Any scarring of uterus has a increased risk of developing Asherman syndrome, and tuberculosis obvious cause. So answer will be following vaginal delivery. Okay, somebody was asking about the genital TB treatment, diagnosis. See, that is going to be a very vast thing again. So I think I will not be discussing very vast each topic. I will not be able to cover a lot of things. Okay. So I have not gone into that part, but relating to the image based, I've asked you this, frame these questions. Okay. If I could have time, I would have definitely done. Okay. See, hydrosalpines, this image I have written it. This is because to just to show you part of this genital TB only. This was a previously asked NEET question. NEET 2020, they've asked same image they have given. So this is about the distal tubal block. This image is about the bilateral. You want previous slide? Other HSG features? Is this slide you want, Mukesh? Click it if you want to. Take a screenshot. Okay, done. Asherman slide. Okay. Okay. Okay, we can go fast. Yes. So this image is about the previous NEET 2020, where it is about the bilateral hydrosulfings. So what are the causes of hydrosulfings? One is PID, very important, very most common cause for that is PID. And the second most you can see is the genital TB. Next step in the evaluation, when I say a distal tubal block with a bilateral sulfing, so what can they ask question is about what is the next, this one answer, what is the investigation that you do is the laparoscopy. Laparoscopy will tell you whether it's a PID or a genital TB. In a genital TB where it will be studded with lot of tubercles. So you will have a diagnosis and you will treat accordingly. Okay. So the answer will be laparoscopy you will do for the diagnosis. Okay. So image-based questions are hydrosulfings. What are the causes of hydrosulfings? All except PID is the answer, tuberculosis, endometriosis, appendicitis. Which is the answer? Answer? See, answer is D. Okay. Yeah. Okay. Next question is about the Mullerian duct anomalies. See, Mullerian duct anomalies, you have two things you have to by heart that I'm not going to explain it here. One is about the, you have two classifications. One is American AFS classification and Eschker classification. Both classifications are very important. They might frame any type of questions from this. And identify the image. See, whenever there's this kind of Mullerian duct, you think it's a Mullerian duct anomalies, you have to first identify how many tubes are seen. That is very important. That's how your approach should be. What is how many tubes are seen? Here only one tube is seen. So one tube, your answer will be unique coordinate uterus. So the first question, image-based question, identify the uterine anomaly in HSG. The answer is unique coordinate. And what is this appearance is called? In HSG, this is called the banana-shaped cavity with a single fallopian tube. This is the typical description that you give for a unique coordinate uterus. Next, what is the impact on the adverse effect on the pregnancy? That is that's how they frame questions. Another framing point is the what is the adverse effects? One, it can be a preterm labor, can lead to miscarriages, it can lead to IUGR. Okay, these are the most common things, and only with HSG what Mullerian duct cannot be differentiated. Okay, we'll be coming, Dinesh, totally will be coming again and again. We have a lot of things, then we'll discuss. Okay, so these are the adverse effects. Okay, and remember this has an increased risk. What question? Another very, very important point. It has an increased risk for the development of ectopic pregnancy and uterine rupture. Don't forget this. Don't forget this. So this is this anomaly has an increased risk for ectopic pregnancy as well as uterine rupture. Image-based questions, your answer you got. Most common uterine anomaly that is associated with renal anomaly. Again, this is going to be a unique coordinate uterus. This also you have to remember the anomaly that is it was a previous question again. I don't remember the year. Again, this was a previously asked question. Now identify this. See, this is how this is a question which gets a lot of confusion in identification. Okay. So as I told, how do you approach? See, there are two fallopian tubes. So there are two fallopian tubes here. How many vagina? You can see only one. Okay. So it is only one vagina. So either it can be two options. One, it can be, see, there are three confusions here. Either it can be a bicornuate, or it is a septate, or it is a arcuate. That's how you get a confusion. So we have to differentiate each thing. Okay. Didelphys, it's like not at all coming into this thing. Okay. Of the given criteria. So the first picture, so you have an arms like this. So this you keep it as A, this you keep it as B. you can see this two horns like this, which is more acutely like this. So I will rate it as A and B here. So how do you differentiate? This is a bicornuate and this is a septate uterus. When I say bicornuate, how do you differentiate between both? When the angle between the both horns A and B, the distance between the two horns A and B is more than 4 centimeter, and here it is less than 4 centimeter. The angle between them is more than 60 degree. It is less than 60 degree. Then you have something called the intercornual angle. Intercornual angle of more than 145. That is more of obtuse angle. Then it is bicornuate. If it is less than 75 degree, it is in a septate uterus. Very, very important thing. The upper, it is called the heart-shaped uterus. But where here you will have normal shape. Grossly, when you see this, it will have a normal shape, and that is a septate uterus. And very, very important thing from adverse effect is preterm labor. And there is no specific so here when you have to see, there is no specific intervention that is required. And yes, they're talking more about the cleft and depth. Okay, cleft and depth, you remember the cleft is more than 1 centimeter, less than 1 centimeter. See this thing, the cleft and depth, why I'm not talking much about that is, this cannot be as much like for an image based, but yeah, that also you can remember, more than 1 centimeter, less than 1 centimeter. That is one more thing. And what else? Other things you have to remember is, you can do a unification operation. There are many operations, but which you have to know is the Strassman. Strassman, whenever you do a metroplasty, repair it, the uterus, cesarean section is indicated. That is very important. That can be asked as a question. So that's how you differentiate between the bicornuate and the septate uterus. Coming to the next, they were talking a lot of things about didelphys. So this image is about the didelphys. Didelphys is di2. Here you have 2 cervix, 2 endometrial cavity, and they are non-communicating. Okay, again you have 2 fallopian tubes here, and they might be associated with the longitudinal vaginal septum. That you have to remember, they might be associated with longitudinal vaginal septum. What is the image-based question say? See, this is about completely about Strassman is a treatment, that is a unification operation that is done for the bicornuate uterus. Okay, septate uterus, you will normally remove the septate using a hysteroscope. That is only when if there is an increased recurrent pregnancy losses and there is recurrent abortions. Why? Because the abortion is increase in septatus, the fertilized ovum comes and implants in the septa. The septa will not receive that much of blood supply as compared to the surrounding endometrium. Okay, so once it gets implanted in that, it will have decreased any there's no association with the renal anomalies, Muhil. Okay, so it is only what was I talking? Yeah, once it sets implants in the septa, it has increased risk of abortion. So more of abortions and preterm labors is not common in septate, but the abortions are more common in septate. In bicornate, preterm labor is more common. This much difference you have to remember. Increased risk of abortions, especially when it gets implanted on the septa. So this is purely, this question, what I've framed down is purely of the embryology. These are direct questions, okay? So what they have asked is, so complete absence of Mullerian duct is Mullerian agenesis. Complete failure of fusion of both Mullerian ducts. The answer what you're given is uterine diadelphys. So answer is B. We'll see the other options too. Partial fusion of both sides of the Mullerian ducts. It is bicornate. Absence of one side of the Mullerian, it is very obvious, it is unicornate. One more option I can give you. Fused, but septa failed to resolve. It's very obvious. Again, it is septate uterus. Okay. Next, we are talking about the development of ovary. What is the answer? Ovary develops from? Answer? C is the right option. Yes, it's the genital ridge. So quickly, I will tell you what are the other things development. It's very important. One is the genital tubercle. Genital tubercle give rise to clitoris. Genital swelling give rise to labia majora. Genital folds give rise to labia minora. Mullerian ducts, as we know, the whole system developed from here. Uterus, fallopian tubes, cervix, and upper 3/5 of vagina. Lower 1/5 of vagina is by the part of urogenital sinus. Ovaries developed from genital ridge. Remember, genital ridge, which part of the genital ridge? From the middle part. And you have the cranial part, the upper part, give rise to infundibulopelvic ligament. Fundibulopelvic ligament. Bartholin glands develop from caudal part of the urogenital sinus. And the vestibule. Urogenital sinus. Okay. So these things, it's a must that you have to know. These are direct one-liners. They will ask you. So it is important. And what are the next question we will see? Next is about the arcuate uterus. Arcuate uterus. So it is called the flat top uterus. When you see the uterus, it has a flat top. So it's called the flat top uterus. Yeah, so what is true about the image except, see, there is a slight indentation. That's why it's called the flat top. The ratio of height to fundal indentation to intercornal distance is less than 10%. Yes, this is also true. Mostly no adverse reproductive consequences. True. It requires surgery. No, see, it does not require surgery, but you are not finding any other cause for the for the recurrent pregnancy loss, then you might require a treatment. The question, if they say there is no other causes relating to recurrent pregnancy loss, then the answer can be surgery can be done. But as such, doing a surgery for this, since you have found this, it is not gonna definitely stop the recurrent abortion. That you have to remember. This is a direct question. Regression of the Mullerian duct in males occurs at. Answer D. See, remember, these are direct questions. You have to know this. Okay, coming to the next topic. I think I'm little slow. I have to fasten it. Otherwise, we'll lag behind. Okay, what is this image? So this is about the PCOD. It's clear cut, it's shown. Okay. See, a 25-year-old obese woman, she complains of infrequent menses with since menarche, and she has mild hair growth with chin on the chin and upper lip. Her ultrasound shows bilateral enlarged ovaries with multiple follicles, that is 20 to 25. What is the mostly diagnosis? And the answer is PCOS. Okay, the answer is PCOS. What you have to know from this? See, PCOS, it is characterized by obesity. The most thing is cycle irregularities. What else? It is hypoandrogenism. That you have to remember, hypoandrogenism. That is seen as acne, hirsutism, hair, and also characterized by insulin resistance. Insulin resistance, you can see acanthosis nigrans. Okay, all these things all are associated. And you have two criteria. One is the Rotterdam criteria. Another one is the New Estier criteria. Is it screen lagging? Give me a second. Disconnected properly. Okay. One is the Rotterdam criteria. And another one is the Estier criteria. See, New Estier criteria, they say, Rotterdam criteria, they say that is more than 12 or more follicles, ovarian volume of more than 10. Even if you see these changes in one ovary, okay, and you have to talk about it as a necklace pattern appearance. But they have told one thing in New Estier. What is a new change that you have to know? This can be a question. They say it is more than 20 follicles. That only you have to remember. New Estier guidelines say it is more than 20 follicles. So that is about the PCOS. This question is very important, direct question. The drug of choice that is used for ovulation induction in PCOD, initially the answer was clomiphene citrate. Now the answer is letrozole. The answer clomiphene citrate, now see, it has a lot of side effects in PCOS, and it is not that effective. So the answer now, and what they use now, is letrozole. Don't forget, the answer is letrozole. Don't forget, okay? See, I have compared two things. This image and this image look somewhat similar. If I give you this separately, when I give you this separately, this both images, you will get confusion. Okay. So when you see the image, but how they present will be different. It's a, what is this? It's a OHSS. That is nothing but it's a iatrogenic complication. It's somewhat similar in appearance to PCOS, but you will have a bigger follicles here compared to that of PCOS when you see here. Okay. And remember, it is OHSS is a iatrogenic complication of an ART. Okay, iatrogenic complication, that is because of you're giving a GnRH. See, the increased risk is with the GnRH. When you're giving a GnRH, gonadotrophins and HMG has a increased risk for the development of this OHS, especially in a PCOS. Already they have a bigger follicles, and you give it in a higher stimulation of ovulation induction you do, it leads to this OHSs. You have many grades in that: mild, moderate, severe. Based on that, you have the symptoms. Comparing to clomiphene citrate. See, if you have to say clomiphene citrate or the letrozole, when I say clomiphene citrate or letrozole, they have a risk of developing OHS is only 1 to 2%. But when I talk about the gonadotrophins, they have gonadotrophins, okay? They have a risk of some 20 to 30% chance of developing OHSs. And as I told, they have various grades of developing this. One is, what is the factor? You have to see. First, we'll see this question, then we'll see what are the factors that is responsible. A 27-year-old female, she have a history of 3 years of married life. She comes to the infertility clinic and she was put on a HMG treatment. So she was started on a gonadotrophin treatment and she developed dyspnea and abdominal pain. On her USG, you did an USG, you're seeing this following image. What is your diagnosis? The answer we know, it is ovarian hyperstimulation. But why has she developed this dyspnea and abdominal pain? That is very important. This is okay. Why has she developed? That is because this ovarian induction or that will lead to stimulation of the ovarian stroma. So this ovarian stroma also gets stimulated, leading to the production of increased production of VEGF factor. So this VEGF is gonna damage this endothelial cells. That will lead to leakage of this fluid from the intravascular space to the extravascular or the third space. So they might present with increase in hemoconcentration, hypoproteinemia, pleural effusion, with lot of fluid accumulating. They might present with ascites, dyspnea, all these things. Okay. See, this is going to be a very, very important topic. You have a lot of questions. You can expect this question, and I want you to read up very well on this OHSs. I'm not going to go very deeply, but have a basic concept behind this question. And very important question, you can expect this question too. What are the methods of prevention of OHSs? If you're a PG student, I would have definitely said this is going to be one of your question in gynae. See, for NEET, definitely this can be a question. What are the methods you prevent of OHSs? One is, it is because of the gonadotrophin. Okay. So the answer very obvious here, it is increasing the dose and duration of GnRH cannot be a prevention. It's going to harm the patient. So that is going to be the answer. So these are true. Remember, you try to reduce the GnRH dose as much as possible. Decrease the dose, the duration, and the frequency. That is very important. When you do all those things, will lead to unifollicular ovulation, which in turn will prevent the OHSs. One more very important thing you have to know is about the one more you can add, it is in vitro oocyte maturation can also be one of the preventive measures. Controlled ovarian stimulation, that is one more thing. One more you can add is avoid HCG for luteal phase support. Okay, there are two words that you have to remember. One is cycle cancellation and coasting. Though it looks very fascinating to hear these words, what is that you have to know? When I say cycle cancellation, what happens? You decrease the exposure to GnRH by withholding the HCG and preventing the early form of OHS. That is called the cycle cancellation. When See, when I say coasting, when I coast, it's not casting, it is coasting. Have I written coasting? Yeah, it's not casting, it's coasting. It's called soft landing. Soft landing in the sense you will decrease the dose and you see what is the follicle growth. Okay. Then based on that, you will start giving them the doses. That is, you will monitor the follicle growth with the markers like AFC